So I'm Réda Ibrahim, the next speaker. I'm from Montreal, one of the co-director of this meeting. I'm just privileged to be here. Can we adjust maybe the? It's not like the full slide. You want me maybe to relaunch that? Perfect. So next topic is going to be treating the untreatable. Can we consider to close the appendage of a patient with a thrombus? The concept was introduced just previously in the previous talk. It's always better to try to avoid to inject if it's not really need. Definitely if there's a thrombus, if you consider to do the procedure. This is my disclosure slide. Sorry, it's small, but I'm interacting with most of the company for appendage occlusion. So let's start with the first questions. And coming back to the title of my talk, question one is, can you safely, you think, implant a device in the presence of LAA thrombus? And so first answer, no, I will never do that. It's an absolute contraindication. Answer number two, yes, maybe, but I will never do that myself. So you can accept that someone, an expert in the field, can do the procedure, but yourself will not do that. Yes, maybe I can close, and I'm eventually planning to do that at some point in my career. Yes, I did that before, so please answer. So it's interesting. So I don't see well the number, but most of you, I think, consider that it's something that we can do, but you're not feel all comfortable to do that yourself. We see that some operator here did that before, showing that we are trying to push a little bit more the limit of this procedure. So, as you know, thrombus can occur despite different factors, despite acute AFib, especially in patient a recent embolic event. We tend to feel that if a patient is coming with acute AF, less than 24 or 48 hours, there's no risk of thrombus. It's probably false. So, especially in patient with recent embolic event, we can find thrombus in the appendage despite acute AFib. Thrombus in the appendage also can occur despite full anticoagulation. It was in one paper 4% of the patients scheduled for AF ablation despite 4 full weeks of anticoagulation with warfarin. And thrombus can occur also despite low CHAD score. So CHAD score 0-1. Again, roughly 3 to 4% of a cohort of 300 patients. Where we did a T before potential cardioversion. So sometimes we feel comfortable that we anticoagulate the patient for a full month before cardioversion, but even if we did that, in some patients we find thrombus in the appendage. There's multiple predictor of LAA thrombus. Just to mention some mitral valve disease, but this is not a disease that typically we target for LAA occlusion. We typically want to treat patients with non-valvular AFib, patient with a recent embolic event, I just mentioned that, patient with large left atrium, either large diameter or large volume, patient with low ejection fraction. I think we know more and more that patients with low ejection fraction, they have a lot of stagnation in the left atrium, and they are really prone to thrombus, either before or even after closure. Low LAA contraction velocity, and patient with spontaneous echo of contrast. This is all risk factor for real thrombus after. So question number 2 now for you. If you see a patient with a thrombus in the appendage, how you're going to treat that patient? Are you going to prescribe warfarin? This is answer number 1. Are you going to prescribe low molecular weight heparin? Answer number 2. Are you going to prescribe NOAC? Answer number 3. Or you will consider a surgery for this patient? Please answer. So most of you will, so nobody will I think nobody will send this patient to surgery. But most of you, interestingly, would treat this patient with warfarin, so the standard treatment. I think we have all good, everything is a good option in this field. And to be honest, I found evidence for everything. But of course, we have experience with warfarin since a long time, and most of us are very comfortable to prescribe warfarin. But it's definitely possible also to treat patients with IV heparin. Sometimes we see rapid resolution of the thrombus. Low molecular weight heparin, it's definitely also another option. I found more evidence in the literature on enoxaparin for any reason. And NOAC, there's a report now which with each NOAC that is available in the market with clear resolution of thrombus in the appendage. So you can prescribe pretty much what you want, but most of you, as we saw, is tending to prescribe warfarin. But know that everything is possible in this field, and now we have clear reports, and it's all published that thrombus can resolve with any kind of treatment. Timing of the resolution, it's variable. It can be, again, very, very fast, but some thrombus tend to remain for any reason. And in some patients, we see refractory thrombus, and this is what I'm going to address now. So if you have a patient with thrombus that you try to treat, but patient is having a refractory thrombus, it happens so every so often, which technique are you going to consider to close the appendage? Are you going to consider endocardial device, Watchman or amulet, epicardial device, lariat, or surgery for this patient? So for refractory thrombus, please answer. So most of you will, 2/3 of you will consider endocardial device. I think there's no clear advantage of a lariat. Lariat is a suture, but you still need to introduce something in the heart. And I think one of the best options probably is surgery. But often we don't want to send patients in surgery for thrombus. But this is probably, in theory, the optimal option. But in practice, this is not something that we do very often. So if you consider a device, which device are you going to prefer for to treat refractory thrombus? Which concept do you prefer, the Watchman or the amulet? And understand that you can be biased here. Please answer. Watchman is number 1, amulet is number 2. So most of you, it's maybe an audience that is a little bit biased and will prefer amulet, but some of you mentioned also Watchman. Is it, and coming back to my talk, Watchman is not a crazy device to consider in this case. We have now a paper published with 2 case report. This is a paper from Amber. So Watchman for patient with LAA thrombus, it's possible, at least again in Germany. But this is again like the amulet off-label. This is certainly not something that is that we proactively recommend. But this is a paper that was published in Neurointervention last year. They report 2 patients that they were treated successfully with the Watchman without complication, but using cerebral protection device in the 2 cases. In the first case, they used a spider effect system to protect the brain. And in the second case, they used a claret medical montage to close the appendage. So again, 2 cases closed with the Watchman, the device that we typically deliver quite far in the appendage, but using cerebral protection device. Is it possible to close also with the amplatzer in the case of thrombus? Yes, again, it's possible. Again, it's off-label. This is not something that it's the IFU. It's not something that we want to promote actively, but this is definitely possible. We are going to submit right now for publication our experience in Montreal and Spain with my friend and former fellow David Armezendi and Chevy Frexa, the experience that we have on 6 patients now. So 6 patients treated successfully without complication, but in this case using no cerebral protection device. So this is the characteristic of the patients. So 6 patients from 69 to 83 years old, 3 male, 3 female, prior stroke in half of the patients. The reason to close the appendage most of the time was bleeding, but for one patient it was stroke on oral anticoagulation. Different morphology of appendage as usual. So 3 windsock, 2 chicken wing, 1 cactus. The thrombus was located in the appendage as usual distally, so far in the appendage. The anatomy was judged to be good for LAA closure, especially with the amplatzer, where we put the device only in the proximal portion of the anatomy. The device that was used was the amulet most of the time, but for one patient it was an ACP. Again, no cerebral protection device. It was we were able to deliver the device in place all the time. No complication related to the procedure. And for medical therapy after closure, it's a mix of different things, showing that we probably don't know what to do with these patients. So we discharged 2 of these patients on dual antiplatelet therapy, 2 patients on warfarin, 1 patient on enoxaparin, and 1 patient on NOAC. But I think no matter what you do that not based on evidence. The goal of this paper is to demonstrate that we can safely close appendage with this device. What kind of technique that we are using? We are using what we call a no-touch technique. So transseptal under T guidance, typically a stiff wire in the left atrium or in the left upper pulmonary vein. We definitely size based on echo measurement. We are not injecting actively contrast in the appendage. We partially open the ball of the device in the left atrium at the mount of the appendage, pretty much like the technique that we just mentioned, and then we just gently push this device in the appendage to open at the level of the landing zone. So this is one picture showing the thrombus at the tip of the appendage. The device was partially open just to create a ball. I will show you also the triangular shape also that we can potentially obtain with this device, and then we push gently in the appendage. So this is just to show two different aspects of this device. So the device is partially open, creating a ball. For this technique, I prefer to open a little bit more the device, creating more triangular shape. We have also a larger lobe at this point, protecting even more the patient against potential thrombus removal. Because by opening more this device, you have a larger net in front of your delivery sheet. So the device, it's more open, still the hook are not exposed. So it's very safe to push this device in the appendage. And then at the level of the landing zone, you can fully open the lobe. At this point, it's safe to inject, confirming your good position, and then you deploy your disc in place. So I will conclude by saying that thrombus in the appendage are not rare and can be treated effectively, most of the time using different medical strategy, and pretty much everything is possible as I showed. Refractory thrombus, especially in bleeders that you cannot easily anticoagulate, are problematic but can be managed by device exclusion in the presence of favorable anatomy. But again, this is off-label and it should probably be performed by expert in the field. Thank you very much for your attention.